Welcome to the Global Robotic-Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic-assisted surgery, a global key opinion leader in telesurgery, and editor-in-chief of the World Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Robotic Surgery Podcast. This is Professor Hitendra Patel, and I'm very happy to have the President of the British Association of Day Surgery, Dr David Bunting, on the show today. Hi, David. Please, thank you for joining us.
Well, good evening, and thank you for inviting me. It's a real pleasure to be here today.
You're not only the President of the BADS group, you're also a consultant upper GI surgeon. Do you want to just tell us a little bit about your background before we move on?
Well, I suppose I came from a little bit of a medical family. My mother was a practice nurse and worked in the NHS for some 40 years before she retired. And actually, her father was probably what got me into surgery. He was a general surgeon back in the day, very different, I guess, from what I call myself today as a general surgeon. Alas, I never met him. He unfortunately passed away at the tender age of 50, but he essentially was an emergency and vascular surgeon. He was a fellow of the Royal College of Surgeons of Edinburgh and was posted out in India during the war. Came back, worked in Liverpool for a bit, and then finally settled in Broomfield Hospital in Chelmsford, where he performed vascular surgery. And something that my mother always said that he mentioned to her was that as I grow older and more experienced in life, I know more about less. And I think he was talking about specialism, which was a thing even back then, but possibly even more so now. So some of the technology that we have today may be very, very different from the basic tools that he was using. But I think the philosophy behind medicine probably hasn't changed, putting patients first, teaching and training with his philosophy, and yeah, possibly continued specialization. I've had a relatively standard UK-based training. I know that you have speakers that represent many countries of the world and have trained all over the world. My training's been fairly typical of a UK medical school graduate. Graduated from a London medical school. I spent some time training in Australia. I did a trauma fellowship in South Africa, and then I settled in the southwest of the UK, where I did my higher specialist training in general and upper GI surgery. And then finally, after becoming a fellow of the Royal College of Surgeons of England, I found myself in an esophagogastric fellowship post down in Plymouth, and then a job came up in North Devon, where I am now, in Barnstaple, where I practice as an upper GI consultant. I've been there for some 6 years now.
Wow. So a pretty decent journey around the world, though, Australia and South Africa. I was going to say your grandfather or your mother's father, I think you said, when he was working, you may or may not know this, the first video link supervised surgery in the world was by Dr David, the vascular surgeon. So interesting, many, many years ago. So your grandfather probably...
I didn't know. That's fascinating, yes.
Yeah, we always ask for the David, don't we, when we're operating, and there we go. He was the first. But anyway, listen, David, fascinating background. I'm sure you're going to tell us a bit more about you personally as we go through the little discussion we have now. But in terms of your experiences in the world of technology and surgery, I'm sure you trained in a time, you're not that old, I'm sure, but you probably were around before we had the things we talk about now, minimally invasive surgery. I know you're a hernia expert, for example. Tell me, when you went from open surgery to some form of keyhole surgery, was that transition easy, difficult? How did you feel about that?
It's very interesting that you say that. I think as I was going through my late senior house officer training and my early specialty training as a registrar, I think we found then that traditional, what we consider 2D laparoscopic surgery now, was just becoming more popular in general surgery. I mean, clearly it was being used for operations like appendicectomies and cholecystectomies, but particularly with the emergency side, the appendicectomies, I guess in a sense, we felt almost like we were training ourselves, because It was a technology that was coming in and being used for a procedure whilst we were going through that training. And some people have said that the transition from open surgery to laparoscopic surgery, which has been a huge leap in technology and brought about massive improvement in patient care, changes in length of stay and enhanced recovery, etc. Some people are drawing on the parallel with robotic surgery compared to traditional laparoscopic surgery now, and comparing some of those advantages and some of those boosts in performance in that. And now as a consultant, I see a second wave and a second change coming through as the number of robots in the UK is increasing, and we're developing different techniques, and we're using the robot facility to assist us with a different variety of operations. Now I once again feel in a similar situation where perhaps we're driving the learning, and we are undergoing the training ourselves.
I mean, robotics is just, and lap is one aspect, isn't it, of technology in surgery. I, like yourself, spent a lot of time on training people in day surgery. So do you want to tell us a little about that? And because, I mean, that's important. I guess what I'm getting at is eventually we're going to put day surgery with this newer technology, which is what the ultimate goal is. I mean, tell me a little bit about day surgery and open surgery first, and then we'll move on to the technology part.
Well, the NHS England have set us a new target that they want 85% of our procedures performed in this country to be performed as a day case. Earlier this year, the UK's just struck a new high, whereby we perform 81% of our operations and procedures across the UK as a day case, having fallen well short of 80% over the past 5 to 10 years. So that's an NHS England and government-driven aspiration, if you like. And clearly, I won't go into detail with the benefits of day surgery, because I know all your experienced listeners will be well sold on the idea of day surgery and the benefits. But clearly, there are benefits to the patients. They prefer that. They do better. They have much better outcomes. It's much better for hospital flow, for our trusts, for saving inpatient beds and freeing up those valuable resources to treat those patients that do need to be treated as an inpatient. There are efficiencies throughout the entire patient pathway. And then there's a new agenda now in terms of the green agenda and carbon footprint. And people are realizing that one of the biggest ways we can reduce the carbon footprint of everything we do in the surgical process is by keeping patients out of hospital, and that means day surgery. And I think robotics and training in robotics gives us a fascinating opportunity to further reduce length of stay and increase day surgery rates, and that's been proven. And the day surgery feasibility has been proven for a number of different operations, which was traditionally very difficult for open surgery, particularly, but even some forms of laparoscopic surgery. And I'm talking about day case prostatectomy, nephrectomy, hysterectomy, complex abdominal wall reconstruction surgery, which is traditionally associated with something like a 5 or 6 day stay, and there are centres unbelievably performing this sort of thing as a day surgery. So we really are looking at another huge step change in length of stay, which I think is brought about in part, at least, by robots and artificial intelligence and other forms of new technology, indeed.
So, David, if we just to be a little bit philosophical for a second, the nudge hypothesis, I love that process. So the British cycling team, for example, little small changes to affect the outcome at the end. So if we took day surgery as you see it, and I said president already once, I'll say it again. Okay. I found this on the web for surgery. And if we just go with day surgery plus enhanced recovery plus including regional anesthesia plus some form of technology keyhole, if you add those things together, do you think if you add those things together in a nudge way, we are talking about exponential improvements in patient outcome or more linear? What do you think?
Those marginal gains can be very difficult to quantify the benefits of, and particularly attributing particular benefit to any part of those processes. And why such an important part of the process to package them together. And I think in answer to your question, it's going to depend on the operation. We know that the robotic technique itself and other forms of enhanced and modern technology that we have, they lend themselves very, very well to certain operations and perhaps not so well to other operations. I mean, we know that there's still a very good operation for a unilateral, simple, straightforward inguinal hernia in the form of an open mesh repair, a Liechtenstein repair, or indeed a traditional laparoscopic repair, whilst we can do the similar thing robotically. And it may be that that's an operation that's associated with something like an 85 to 90% day case rate, or at least in the best performing trust in the UK. So that's something that with a full enhanced recovery package, we're unlikely to improve upon a huge degree. But at the other end of the spectrum, there are bowel resections where traditionally patients will be in hospital for 4 or 5 days, complex open abdominal wall operations, they'll be in for 4 or 5 days. Dealing with the overweight and obese patients, as we increasingly are, is associated with longer lengths of stay from some straightforward operations like hysterectomies. They may be in for 2 or 3 days, prostate surgery, etc. And I think those operations where traditionally we've been looking at multiple days length of stay, certainly there could be exponential changes that we're looking at. As I said, feasibility of the day case operation has been proven in colectomies with anastomoses unbelievably. So it's that sort of thing that we're looking at. And I think for certain procedures, certainly could be exponential.
Well, listen, I was very excited that you were going to come on the show, because it would be remiss of me not to ask, do you think we should change this whole definition of length of stay? I mean, we're talking about traditional length of stay, which is in a secondary care or tertiary care facility. Do you think we can go to a more, US model where we've got these halfway hotels scenarios? Do you think that's going to be a positive thing for us?
Yeah, a hybrid approach could well work. I mean, I think with the one thing working in the NHS that we'll all be acutely aware of is how we are so closely bound to our resources, and we are taught and trained to use those resources widely. And I think that's probably a healthy value at the end of the day. But with that in mind, I think we need to look at all the potential ways that we can improve the patient journey in totality, improve patient flow, and reduce our in-hospital day case rates. And I think we need to challenge the idea of what a traditional hospital is. Yeah, is that a Victorian ward with wide beds and thick mattresses, or are we talking more of a hotel with a guardian of care and somewhere a halfway house where a patient can be looked after? I mean, in the world of day surgery, we see it as a challenge to get people home, and we don't like to be beaten in that challenge. And there are a number of initiatives that we look at. For example, when patients don't have a carer at home, it's traditional after a general anaesthetic for the vast majority of operations for patients who've had a general anaesthetic to be mandated to have an adult carer at home. Well, some patients don't have that. So there are halfway house opportunities there. There are other models of care where we can bring in a community team. So it might be an allied health professional, a nurse that could stay with a patient in their own home overnight. And that's a fascinating one in itself, because when you put that option to a patient where they have someone unknown in their house looking after them for the 24 hours, often they can find a friend or a family member to come and look after them instead of that. But yeah, I think there are a number of models of care that we need to look at and get away from the traditional notion of what an inpatient hospital looks like.
I was smiling because you mentioned the Victorian era. I think I'm old enough to remember that one. But, point well made. And there's lots of scope, isn't there, to change how we work. And you've elegantly mentioned a few of those. So again, with your skills in the day surgery area, and your other skill in anterior abdominal wall reconstruction, I mean, can we just talk about that for a little moment? Because there are lots of people who are listening and watching this who perform primary and secondary hernia repairs, complex, non-complex. Can you just take me through, because I know what they want to know about, because for your anterior abdominal wall reconstructive teams, if they're complicated, can you just tell me how you put a team together to help you with those sorts of surgeries? What sort of team should be involved with taking care of those patients?
Yeah, you're right. You picked up an important point. My practice it can be quite polarized in a way, from the typical day case open unilateral hernia repair that we're all used to dealing with, and many surgeons across the country and the globe are familiar with. And at the other end of the spectrum, we have abdominal wall reconstruction cases. I've got a case in at the moment and she's been here for the last 6 days, and that's not uncommon with what we call sometimes call a Cape to Cairo incision, or incision from the xiphisternum to the pubis, and a big open operation involving drains and several night stay. What we have to support care of those patients, we have a full multidisciplinary team and a regular weekly multidisciplinary team meeting. That team is composed of trainees, very importantly, of consultant surgeons. We have a physiotherapist as part of the team, and we have dietitians. And we're lucky enough to have allied health professions in the form of advanced care practitioners who support us as well. So we run an MDT, and we have a hub and spoke arrangement where we can link virtually with other hospitals in the region if and when we need to do that for that purpose. We offer a multidisciplinary clinic to our tertiary patients when they're referred to us. So we will have double slots for patients and see them along with our advanced care practitioners, hopefully with the imaging. We'll use technology with our digital electronic patient record, so we can instantly take pictures of their abdominal walls, which is very important. A picture certainly paints a thousand words in the world of abdominal wall and ventral hernia surgery. So we upload those to the digital electronic patient record. And then that's followed up, as I said, with a multidisciplinary team meeting where we discuss them. And important things like pre-optimization. One of the hugely important parts of the patient journey in abdominal wall surgery is pre-optimization, and that usually comes down to modifiable risk factors. For example, smoking cessation, diabetes management, getting HbA1c down, and quite often targeted weight loss. So all those things have been shown to improve patient outcomes, and they are the things that we focus on. And that is no different now that we're embarking on a robotic abdominal wall program to try and entrain the potential advantages that we know the robotic platform may offer us and may offer our patients. But the process is the same.
Okay. So if you're adding in that, dovetail nicely into that, if you're adding in robotics, can you just take us through how you got to this point? I mean, first of all, was it financially a viable option for your hospital? Firstly, secondly, what about?
So it's a very interesting point. Clearly, the robot in our hospital was built on a business case that did start with abdominal wall surgery. That will be expanded to include urology and colorectal surgery and gynecology surgery in due course. But clearly the capital outlay is huge. And I know there's a massive surge in the uptake of robots from a number of our industry partners in the UK at the moment. Yeah. So this will be something which is important on lots of people's agenda. But it's important to build a strong business case. And that is based on potentially improving patients' outcomes and potentially reducing length of stay, which in turn can raise efficiency savings for the trust in question. But it's also a question of being able to equitably provide patients with the same high standards of care as they would get in any part of the country. And I'm a true believer in that one of the core values of our healthcare system should be free and widely available access for all our patients across the UK to the greatest technology and the greatest care. So we shouldn't have pockets of excellence in the UK where there's a postcode lottery and patients can access that, whereas others they can't. So that's something that I'm a strong believer in, and I think that's part of the agenda when you're looking at pushing a business case through your trust to get these. So yes, the capital outlay is certainly important, but we'll look to audit our data closely as time goes on, particularly with regards to length of stay and ongoing revenue costs to see how we're doing in that regard.
Interesting, you mentioned the postcode lottery. We just had a conversation about this and with neurosurgery and democratizing that in terms of robotics and how you can stabilize outcomes was one of the kind of comments made. Do you think, just instinctively, I know we can't be sure, but instinctively, do you think using technologies like robotics will standardize the complex anterior abdominal wall surgery and therefore standardize outcomes? What do you think?
I think there's certainly room for that within abdominal wall. We've just had new international guidelines have been published in Hernia on behalf of the British Hernia Society, and it's those sorts of pieces of work that are helping to highlight variation across the country and helping to try and standardize protocol procedures and therefore hopefully outcomes. And I know that the British Hernia Society are also developing a hernia registry, which we hope will be widely available across the UK soon. It may even be a sort of mandatory component, but it's big data like that hopefully we can link in with technology to make sure that we are producing standardized results across the country. And as you will know, that getting it right first time program and initiative from NHS England is all about highlighting variation across the UK so that we can bring those lower performers up nearer and closer to those higher performers.
I know you've been involved with GRIFT, so it's good. Thank you for highlighting that. Because yes, getting it right the first time is crucial, isn't it? But I was interested that the data you're talking about, the database with the British Hernia Society, that's another phenomenal initiative, a bit like the HIPS, mandatory HIP registry they have. You know, it's really improved outcomes, lowered infection rates. So do you think if you fill out a form every time you do an operation, that makes you as a surgeon more aware of what you're doing, and therefore do you think that helps with improving outcomes? What do you think it is? What is the reason things get better?
I think, yeah, that's something that Atul Gawande always said. If you've read his books, he has always said that the data is key. And actually what you should do is you should look at your data, you should write it down and you should publish it. And I think in just knowing, learning and understanding your data, going through that process in itself is hugely important, I think it would be remiss of any surgeon to carry on in practice and not think about that in an objective way. So yeah, key is in the data, and we must record it, we must analyze it, and we must act on that.
David, you keep saying amazing things. Atul Gawande, so for those audience members who don't know, this is the man, the orthopedic surgeon at Harvard, who actually coined the WHO checklist and published it in the New England Journal of Medicine. In fact, the WHO checklist was launched in the UK, and I was happy to say I was part of that group, and we met Atul. Amazing man, amazing guy, and clearly a very good writer, right? So let's move on because this is about you, David. So you've had a phenomenal career to date. You're doing amazing things. You're trying to make changes. You're trying to change behavior, change the way we work for the better of patients and our colleagues. So how do you, as an individual surgeon, human being, what do you do when you're not working to keep yourself balanced, keep yourself energized, keep yourself healthy?
Well, I guess family's an important part of my life. I'm lucky to have a quiet house at the moment. My teenage daughters are making use of a late night shopping in town this afternoon, and my wife's attending to her horse, but that does leave me some time for my own hobbies. I like to keep fit, a bit of a home gym, calisthenics enthusiast, that sort of thing. Used to ride bikes a lot competitively, but yeah, frightened of being knocked off the road these days. So yeah, try and put those dangerous pursuits to bed.
I thought you were going to say the middle-aged man in Lycra. That's still me then, not you.
Yeah, when I get the time.
So the audience, the younger audience particularly, are interested in, surgeons like yourself and how you manage your days, when you're working, because surgery can be very stressful. So when you're at work and things are a little bit stressful, what do you do to manage that stress?
I'm lucky that I work in a relatively small office. I know some people work in big offices that are noisy, where there's a lot of people working. It can be difficult to take a break from the hustle and bustle of everyday working life. I work in a small office with two very close colleagues in the Department of Upper GI Surgery at North Devon there. And they're friends as well as colleagues. So bouncing off friends, I think, is very important. It's very important to have friends, to keep friends, someone that you can talk to for a second opinion, and the sort of friends that are not frightened to put you on the straight and narrow and tell you when you're wrong. And those sorts of things can be helpful and supportive, even if they don't feel like it at the time. So having friends is important. Making sure that within the work schedule, you take some time out for yourself for whatever activities that allow you some mindfulness, or to take your mind away from work, and give you the time to look after yourself.
Well, David, it's been an absolute honour and pleasure to talk to you. You're doing amazing work. Please continue to do that, and I hope we get a chance to talk to you again. So thank you for that.
Thank you very much for the opportunity.
This is the Global Robotic Assisted Surgery Podcast. I'm Professor Hitendra Patel, and I hope you enjoyed that episode. Take care.
Thank you for listening to the Global Robotic Assisted Surgery Podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.